Welcome to the November Coffee with a Clinician. I'm Clayton Powers, and I'll be facilitating this series. I'm a doctor of physical therapy specializing in the care of individuals with complex health conditions, and I'm also serving as the education liaison at BHC. Before we begin, we want to thank the generous donors whose support makes our community programs like this possible. For this session, please put your questions in the Q&A feature at the bottom of your screen, and our panelists and members of BHC staff will answer as many as we're able to within our time today. And as a reminder, we cannot provide medical advice. Today, we're going to continue our discussion on navigating clinical uncertainty, this time focusing on how patients and caregivers can tailor communication with healthcare providers with the aim to improve your medical care. Our panelists will share practical strategies that have helped them to advocate successfully within the complexities of the U.S. medical system. So today, we're super excited and privileged to be joined by our panelists who have volunteered their time to share their experiences. First, Amy Mooney is an occupational therapist and mother to a young woman who has had severe ME/CFS for several years. Galen Warden is a mother to an adult male with very severe ME/CFS. Harper Metz is joining us as a family nurse practitioner and spouse to a person with ME/CFS and coexisting conditions. And Sallie Rediske is a medically retired physical therapist and has had ME/CFS since she was 8 years old. If you're a patient or caregiver, we recognize that it's difficult to obtain effective and compassionate medical care. Bateman Horne Center has created resources and guides to help you share scientifically and clinically validated information with your providers. However, we know that many of you are still missing out on the care you deserve, but we hope to share insights that can help you when working with your healthcare providers. During our October Coffee with a Clinician, several people posted in the chat that their medical providers often don't read or incorporate recommendations from the Bateman Horne Center Clinical Care Guide or other information shared with that. I know from my own personal experience trying to share with patients, giving them resources to give to their doctors, and sometimes even communicating with their doctors has been a challenge. So I'm super eager to hear what our panelists have to say. Harper, as both a clinician and caregiver, what have you found most helpful or successful in dealing with this challenge of communicating with other healthcare providers?
Yeah, thanks, Clayton. It is a common challenge when visiting a healthcare provider. How do you get your information that you need across in a concise and brief manner? What I've found most helpful being a clinician and a caregiver is coming to the visit prepared with 1, 2, or 3 topics that need to be addressed during the visit. Once you bring those topics, you can then take the clinical care guide and take excerpts and paste them or share them for that specific topic. It could be ideas about testing, ideas about treatment, ideas of things you may want to try. By creating a more concise, short document, it's either easier for the clinician to glance at during the visit with you and come up with a plan together. I've also found it helpful to kind of model from the patient's perspective this curiosity and collaboration by saying something like, I know that ME/CFS is not well understood right now and it's not taught in many medical programs, but here is the most up-to-date clinical guidelines about things that we can do right now to help me. And I appreciate your help in my case.
I love that. I love that. Telling them that you understand that it's not necessarily well defined and that, there may be limited research. That way you just validate that they may not know that much about it. I love that. Galen, You're known for being a demanding diplomat. What are some phrases that you've used when working with healthcare providers for being able to help them understand your son's specific needs?
I start out by explaining to them that this is something they've probably most likely never seen before, that we understand this is unusual, and that doesn't mean that it's psychological or, anything like that. But I am able to sort of set the stage that we know this is not, something typical. And from there, I can discuss the neurological aspects, such as he's not sensitive to light. Light actually hurts his brain. He's not sensitive to sound. Sound actually hurts his brain. It's neurological. And by kind of framing the symptoms this way, the medical provider becomes very curious and is much more open-minded to, I do want to read a little bit more about this.
That makes sense. I know you've mentioned before that framing it as a neurologic condition is a lot more helpful because then they have more familiarity with
Right,
neurologic conditions,
right.
like a concussion, for example. Many providers understand that when you have a concussion, you may not feel good, but then framing it as it's
Yeah.
not just sensitivity, it's more than that.
Right. Plus, also the way that you sort of say it and present it, as to try not to be either apologetic and, and to be like a wimp about it, but at the same time, you don't want to be combative and you don't want to, be arrogant about it. So just saying, it's this is a neurological condition. You wouldn't say that to a neurologist. This is, something that you've got to sort of think about your audience and what is their, what are they going to have to do for you. I'm talking about like a GP, because when we first had nurse practitioners come to our home, we use a South Carolina house calls. And when they first came to my home, we had a bad experience. I was new at this, and the person just didn't believe us. She said he could walk if he wanted to. And I just, I got off the phone crying when she did that to me, because it was as if she totally didn't hear anything that I said and I wasn't saying it right. So we got another one. We got a different nurse practitioner. So the new nurse practitioner, I prepared her before she saw my son. This one, I just walked her into the room and she saw my son lying there, totally incapacitated, an eye mask on because we put the light for her. And she just, immediately blocked everything she was seeing out. Where the new one, I sat her down and I said, this is going to be something really weird you've never seen. And I sort of set the stage for her to meet him, because, these people have to see them physically. They can't just take your word for it. So that was another really important thing that I did.
That's super helpful. Do you use resources as well, like handouts or other things to
Yes,
give them?
yes, exactly like Harper was saying. Concise paragraphs, one page out of a 40-page document, exactly what the person needs to know about your situation printed. And so what I did for this second nurse practitioner was I only had about 4 or 5 pages printed. I had things from the CDC, I had things, from different resources, and I just highlighted a paragraph or two. For example, there's a PDF where they mention lorazepam for heightened stimuli. This is really important for my son. He takes lorazepam, and she had to know that this was clinically approved by people treating his condition. So I had that printed, and after the conversation and after seeing my son, she was super receptive for me to hand her all these papers.
Yeah, and you mentioned that saying, "Oh, my son has ME/CFS or ME," was maybe not as helpful as saying a neurologic condition.
Right. They don't know, they never heard of it, and it kind of it sets them back, like what's going on. You don't want to give them anything extra to think about, to work out. You want to make it a very smooth, efficient conversation. And the smoothest, most efficient way is don't try to overeducate. the simple needs, these are the needs that we have. This is why he's this way, she's this way. Those are the most beneficial, because you want them to be your ally. You don't want them to feel like, you're here to show them what's what.
That's super helpful. Thank you. Sallie, I've heard you also say you will sometimes read a pre-written brief statement or give the healthcare provider a pre-written brief statement. Can you tell us a little about that and what you include?
Yeah, over the years, I've found that especially because of all the medical trauma that I've experienced, having developed this at such a young age in a period when nobody knew at all what was going on, um, I've found that writing something very concise and very specific, and then going in and reading it to the provider as opposed to relying on my heightened emotional state, which is often really triggered with adrenaline. And I can get really chatty and really pretty agitated, and sometimes kind of start talking in circles or even go down rabbit holes that are not appropriate for exactly what Galen's talking about, staying on target and keeping things structured. And I think it presents, it gives the provider a sense of, this is not going to get off target. This is not going to get out of control. And they're not going to get overwhelmed with this really complicated patient. And then they have also something that goes in your chart that says, puts a really concise, particular message in the chart for future reference.
Can you share an example of what you write? Like, or would it
Yeah.
be unique to that appointment?
Yeah, one of the things that I do is I very specifically state that I have experienced medical trauma and that I actually do carry a diagnosis of medically induced PTSD. So if that is your life and your experience, um, say it, because that has changed how doctors react to me in most cases. Most doctors respond to that. There are a few that have not, but they seem to be more willing to they just change their tone and how they interact. So that's the first thing that I include, and that's why I am having to write this out. And then I actually follow a lot of what Galen's saying, that I don't elaborate a lot on ME/CFS, but that I have a complex chronic illness. It includes these particular problems, focusing on what my immediate symptoms are and how it might impact their specific specialty. So if I'm seeing a urologist, this might be, my chronic condition might impact you by blah, 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 and specify. And I just stay away from the ME part specifically.
That's helpful. I think, like you were speaking about how you advocate for yourself, having the pre-written statement for people with severe, very severe ME who urgently need medical care, but may not be able to do that for themselves. Do you have any recommendations? Because one of the questions we have is social workers don't know enough or may not be able to help. And so how can someone with very severe or severe ME be able to advocate or receive the help they need?
That's an incredibly difficult situation, especially for people who live with this, who are on their own, which that is a very realistic scenario. One of the things that I've been looking into and using and advocating for people that I communicate with is to use AI. And they're free AI sources, and so people that can verbalize, text to speech to text, can use AI to help generate some type of letter or, a list of what they need to communicate to their doctor, that kind of thing, or, ask a care provider to do the same thing, so that there's fewer steps involved and less cognitive input, hopefully. and then certainly for the people that do have care providers, the care provider being conscious of, what patterns are they seeing, where's this person struggling the most, and just applying exactly what I said, but turning it from, being the care provider writing this letter and using it in lieu of the patient themselves speaking when the patient can't speak.
Yeah, that makes
Can
sense.
I
Oh yeah, go ahead.
Can I just chime in a little bit? My son, when he had surgery, they took him away from me, in my mind, way earlier than they needed to. I wanted to be with him until he was unconscious. So I knew that this was going to be the scenario. On the phone with the medical team, I had asked, how long will I get to stay with my son, et cetera, et cetera. So he was alone. He wouldn't be able to communicate with them, the mask and the headphones and the whole thing. So I wrote some phrases on a few pieces of paper, and I just put them on his chest as they took him away. And they said things like, please replace my eye mask and headphones before I wake up. Just really simple things that, I am extremely whatever, whatever. They were just like a few, not very many, but just having a few words on one piece of paper and just having them with him, I was able to feel a little less, terrified.
Yeah, so it was your way of kind of helping him communicate when he
Right,
couldn't.
right.
That's a good idea. And ideally, a lot of people, or ideally, people would have a caregiver. I know it can also be extremely challenging to be a caregiver. Amy, I'd like to hear your perspective. I've heard you say as a parent, it's your job to interpret your child's illness for the healthcare provider, because sometimes children and teens don't necessarily have the language to explain their symptoms. So how can parents or caregivers develop that interpreter mindset while letting the patient still lead the conversation?
Yeah, I think this is a brilliant question because for children, and I mean, this is for all ages, but for children especially, they don't have the developmental experience that an adult has had. They have known how to advocate for themselves in the past. They may not have it. It's more of a situational loss of autonomy. But for a child, it truly is a developmental piece that their autonomy hasn't been built. They look to their parents to care for them, to speak for them, to cover all their needs. And then they enter a medical community who expects the children to tell the story. And that just is not developmentally appropriate. So I think, a lot of times parents have been targeted for speaking for their children. And I think it truly is, it's not unique necessarily to ME. It happens for many, many chronic illnesses or disabilities. But for ME, it can be a processing difficulty. It can be, what do these symptoms even mean? And how do I put them in some sort of organization? When so much hurts, how do you answer a doctor for, why aren't you going to school? And so that piece of it, I kind of tried to help, the children that I service and my own child, to prioritize their function and their symptom exacerbations or symptom presentations for what is limiting their ability to do their ADLs. I'm an occupational therapist, so I'm looking at what are the jobs of your day. So what is it for just daily functioning that this particular doctor or this medical team can help you with? And so for parents, I try to recommend, this is not your childhood. This is something that is completely different. This is somebody that is going through a medical illness that is misunderstood, and please check your own baggage at the door so that this child can get better service maybe the parent does have comorbid conditions themselves. Maybe they do have a minor or a mild form of ME, but this isn't the place to talk about that with the medical providers, because it's your job as the parent, as the caregiver, to really voice what is impacting this child's their function. And then my second piece is that letting the clinician know that you are just the voice. You've already gone through the language with your child. Your child has already told you what symptoms they are most experiencing. So you are just there to represent the child's needs, so that it doesn't get turned around and blamed the parent for catastrophizing. This is not the place for that to be put into the conversation at all. And so that's why I think it's really important that the parents say, these are my child's words. This is the example my child is giving me on how these symptoms are interfering with their daily function. So try to use it as child directed as possible, and take the personal stake that we do as parents. We kind of re-envision what it was like to be a child. This isn't the same thing. So that's my main piece of using pure examples of how this illness is interfering with the childhood, with daily function, and then helping the child really express those needs to the clinician.
That's great. Do you, for patients who don't, or people who don't have a caregiver, I'm sure you have a lot of patients who don't have a caregiver or don't have a doctor who is able is helping really. How do you advocate or help or instruct them in finding a provider?
I think there's two parts to that, because finding the provider is it's an obstacle. I think it's finding somebody that has an open mind and is willing to just hear you is the first step into it. Because I think if you find somebody that is open, they're trainable. You can make connections. You can get them access to Bateman Horn documents, if they're open to that piece. I also really recommend, and this is what I hope to be able to offer patients, the community, through the Bateman Horn documents, is to kind of give a sample document to organize your symptoms and how your function is impacted, so that when you go to the medical providers, you can not wish, you want this disease to be cured, but the reality is you just need one symptom at a time managed. And so it's kind of refining what having some sort of control over orthostatic intolerance would do for your day. What kind of influence having GI mobility, having some sort of GI relief, what that would do for your day. What does that do for your function? And so I think it's kind of taking symptoms in little batches to say, this is what I need from you as a provider. And I think this particular provider that you're meeting with has the best skills to address X, Y, and Z individually. So that's what I think. I try to help my patients identify what little golden nugget do you want from this particular provider, so that you're not giving them the whole basket of symptoms, but one piece at a time. So that's what I think is the most useful for kind of picking off a few of the low-hanging fruit.
Yeah, it's helpful. Yeah, it is often they can't address everything because of limited time and things. It can be really hard.
Yeah.
Harper, as Amy touched on being a caregiver for children, but also as a caregiver for an adult patient, are you often questioned or met with skepticism? How do you handle that?
Yeah, being a caregiver to an adult patient is also an experience. I am often met with skepticism, or why are you talking for this adult? Why are you sharing this information? Um, Galen had a great suggestion of starting the visit with sharing that I am this person's medical power of attorney. And that really helps to kind of set the tone for the visit, why you're there, and what important information you have to share. Um, when I'm met with skepticism as the caregiver, um, I try to just bring in relevant pieces of information like medication side effects, or different ways that the symptoms are impairing the patient. I try to just add information to what my spouse is already saying. I try to support my spouse in what they're saying and help to get a point across that they may not be making very clearly. And if all else fails, sometimes I'll just kind of call it out and say, hey, I know it's kind of weird that I am this caregiver for this adult that seems okay. But really, ME/CFS is a complex chronic condition, and it really takes collaboration between all of us to kind of manage and make sure all of the information is getting shared at this appointment.
Thank you. Do you have any thoughts on one of the questions we have in the chat is thoughts on communication difficulties and sensory experiences for the surrounding neurodivergence and navigating this? Do you have any thoughts on how to explain that to a healthcare provider, or yeah, how that affects the treatment?
I think to kind of model what Sallie shared earlier is just kind of put it out there. If you have medical PTSD, share that, and that kind of can help soften the providers a little bit. If you have sensory difficulties with autism spectrum disorder or ADHD, share those. And a lot of times, I think we expect providers to be trauma informed and kind of already knowledgeable about accommodations, but unfortunately, that's just not the case in our current medical system. So sometimes you have to ask for the specific accommodations that you need. If you need the lights to be turned down during your visit, please ask for that. I have no problem when a patient asks me for that. If you need to communicate through writing primarily, speaking is hard, ask for that. I generally find that when patients ask for things that they need directly and concisely, it's easier to accomplish those goals.
I love
Can
that. Oh yeah, go
can I
ahead,
add
Galen.
something real quick? The exactly what she's saying, get that up front. It can be the very first thing that you say. I have some cognitive issues or whatever it is you want to say. So I'm going to need special accommodations in this visit, such as please speak to me slowly and clearly. Please be patient with my response. Whatever it is, don't be embarrassed. This has nothing to do with being judged or, your ego, and get that out of the way. You want this visit to go efficiently, and that's the best way to help it happen.
And
I love
I'd like
that.
to piggyback on that is that's not going to come to your thought process during the appointment. So it's to spend a moment before and kind of prepare yourself and maybe write down your own notes to say, I need the lights turned down. I need to wear my headphones. I need to, ask for a quiet room beforehand. So make a list of what makes this appointment successful. Is it that the provider, speak to you in a low tone or low voice, or actually give them the details directly, but already have thought of that if that's possible. So that's my recommendation is this isn't going to come to you in the moment of the event, but really it's the work beforehand.
Yeah, and that can really help since appointments are really short in the healthcare system. Other than physical therapy, like I have an hour with each patient, but for the most part, medical appointments are really short. And so having that written down, very simple, I think most providers would at least, it will set the tone before they see you of, oh, I need to go in with less energy, less bright lights, and kind of be a little bit more respectful of that person's energy level. Sallie?
Yeah, I wanted to add to all that. I would even go one step further in the process back, and I made connections with the front desk people because the process actually starts there. You know, who picks up the phone, who does the scheduling, who interacts with you in the front waiting area. And over the years, I found that if you can explain to them what's going on with you, and if you can get them on your side, then you have a really powerful advocate in the office. And you know, they'll I mean, I'm not saying this guaranteed, but very often they'll help you facilitate, you know, connections with the nurse in the back when you need to talk to her, and they'll, you know, maybe work harder to get you an appointment when you need it or whatever, if they understand the challenges, the specific challenges. And really the front desk people, they don't have any idea what's going on in the back, and they don't really understand what your particular situation is and the complexity of it and how hard it was for you to get to the appointment and why you might be on edge when you get there. And I just think it's you know, like Amy said, you know, take even a, you know, a checklist, literally a checklist, and just go down it with them, you know, from the front desk to the back, you know, of, you know, I want to lie down, I want the lights down, I want this, and don't be afraid, and communicate with them. It makes their job easier too.
Yeah, and you had mentioned that you also wrote a letter to the front desk staff at one point expressing
Yeah.
appreciation. Tell us a little bit about that.
Yeah. So in over the years, I've sent cards to the front desk people at different places, at different doctors' offices, and it's always made a big impression because, you know, first of all, like, you know, not many people get mail of a positive nature anymore. And so I think it really makes a big difference in them remembering me, and recognizing that, you know, in there I just take a moment and explain a little bit about, again, mostly about my PTSD, and and then, you know, they remember it, and are always super supportive of me, and it just made a little more human connection, I think.
I love that idea of the front desk staff. It's often hard because they're the ones who don't really know much about these conditions, and so they may not be as accommodating. But if you do kind of help them to see you positively in a positive light, they want to help. Most people
Right.
want to help. It's just they don't. They get intimidated or, um, yeah. So also virtual appointments, if we can touch on that. How would you ask for a virtual option?
I would do, you know, the first thing, like with Amy's idea of, you know, being prepared when you go in. If you are making contact early on with a physician, you know, for the first time, I would explain to them that that's, you know, the optimal way for you to interact, and is that a possibility? And then, you know, certainly then go back and circle through with the scheduling department and see what options are available through that particular facility. Again, once, if you've established that kind of relationship, if you just pop out and say, you know, I need a virtual appointment, it's not going to go over well. But if you take some time and educate the person on why, and kind of let that settle in for a little bit, you know, not just load them up with information and then turn around and say, you see why I need that virtual appointment? I think it goes over better, and there's more likely that you will actually get what you need.
Thank you. Galen, you in working with individuals with severe, very severe ME, it can be really hard to see where do I go to get help? Who can help me with managing my care? Do you have any suggestions or recommendations for finding
It is so
help?
hard. Yeah. If you don't have a family member of some kind or a close friend or something to help you with this, it's going to be extremely challenging. I have written a blog post called "You Need a Caregiver," and at the bottom of it, I kind of help with the sort of profile that you can put on a website like care.com, where there are caregivers, not necessarily through Medicaid or whatever, because sometimes people that are very severe, even though they can't even barely walk a step, don't have disability because they don't have the bandwidth or the support to go through that process. I mean, we're talking about nearly impossible situations, but if you can find somebody, a volunteer of some kind to help you and just explain, here's a resource, here's the information, if you could help me get a caregiver, this way. I do want to say that in general, people want to be helpful. People do care. Strangers even do care. And if it's possible to reach out to a church, a synagogue, any kind of a volunteer community organization, the seniors group or whatever, I found that the seniors, even though they themselves aren't like, full of energy and stuff, are extremely compassionate and giving. And if you could reach out to a group like this and say, I'm a person with special needs and a chronic condition, and I need support, I bet you're going to find somebody in that group that will, share that information, talk to the other people, and find somebody that can come to your place and, get the understanding and the compassionate help for you that you need. I know it sounds weird, it sounds awkward, embarrassing, whatever, but if you start the conversation with, I have very special needs, I need special accommodations, and I just can't handle this for myself. Is there anyone that would volunteer to just give me a hand for a day and help me, get something going? You'd probably find that after that day, they'd be very happy to come back, with a pot of soup or, do more things for you.
Do you think would they be a reasonable person to have also become a medical power of attorney, or no?
I don't think so. That's a big commitment they're probably not going to feel comfortable with. Medical power of attorney is something you really need with your primary caregiver. It should be a family member if they're compassionate. If your family has rejected your illness and you don't have any family member, it could easily be a friend. But it has to be somebody physically in your area because they have to physically, sign a paper with you. So what you do on the medical power of attorney, and sometimes it's called healthcare power of attorney, it's different in every state. Actually, on my blog, galenwarden.com/resources, at the very bottom, I have the Utah power of attorney because of Bateman Horn. But you just say, this person can speak for me regarding, my medical conditions, and then that person has to scribble a signature. My son scribbled his signature once, and then I put his initials on all the other places they wanted him to initial, which was about a dozen other places. He couldn't do that, but he was fine with, doing his one-time scribble of his signature. And then I can get lab results, I can talk to doctors about next steps, I can schedule appointments. You can't do any of that. I can talk to the pharmacy about his drugs. You can't do any of that, even if you're the parent of an adult. The fact that you're the parent means nothing to them if they're an adult. So the medical power of attorney is essential to get as soon as possible.
Thank you. Amy?
Yes. So I was going to also mention about when people, and I know people that are severe and very severe, this is extremely overwhelming to hear so much information about caregiving when caregiving is, that unicorn. It can be so in the right kind of caregiving, because there are definitely people out there who would love to be involved in your life, but you cannot tolerate their intensity or their touch and their perfume or whatever it is that is going to be triggering symptoms for you. So I hear you and I understand that. And I hope that some of these ideas are just little light bulbs that can help generate some, even if it's just a little tiny morsel of help for you, just to lighten your load a little bit. But one recommendation I would have is if there is somebody in your life, whether it's a neighbor who you never have talked to before, that somehow if there is somebody that is saying, I would like to, to give you help, I would like to do something, for you to have already thought of one item for them to do. If it is for them to be able to refill your medicine pill box every other week, or to make a couple phone calls for you, I think to already have some ideas of what would be helpful for you to hand off to somebody else. And it's not necessarily, to help you with some sort of cleaning or grooming activity, but just how do you get a fresh pillowcase? How do you get something that's just going to improve your life ever so slightly? Have those already thought of, write it down or record it in your phone notes, or do something that you're not going to have to think about when that person asks you the question of how can I help you? I want you to already have two things that you can go to and say, here, do this, and this will help me. So I hear you for saying how intensely debilitating it is for those especially that are severe and very severe, and not everybody does have access to care. So I'm sorry that that is the reality for a lot of people, but I want to be able to offer a little bit of outline for you that that help can be kind of generated or developed for you.
Sallie?
Yeah, I see a lot of the comments in the Q&A about why are the patients the ones that have to bear this burden of educating and carrying the emotional weight for the providers. And believe me, 48 years this year of dealing with this, and I feel it's a huge paradox of how to navigate the challenges of ME and other complex chronic illnesses too, not just ME, but especially ME. And what I would say is, number one, it is absolutely completely unethical. It is unfair, and it is actually malpractice. That's my feeling. But secondly, when you live it, you are not getting what you need if you rely on just expecting them to meet you. It will not happen at this point in history. And so your choices are to continue to try to run the gambling game of finding a provider that will meet you where you need to be without you meeting them where they are. The odds are very, very low that you will find that person. And so many factors have to come into play. They have to be educated in me. You have to be able to afford them. A lot of them are out of network. They don't take insurance. They don't take Medicaid. They don't take Medicare. They're geographically not located where you are, all kinds of things. And then, so you have to deal with all of that. And so what you're doing is preventing yourself from getting actual help that could be kind of nurtured out of somebody that could actually grow into a relationship that is workable and trainable. And that's what we're doing, is we're actually training these people to be usable and helpful. And what's happening on the other side, though, is a hardcore effort of advocacy and effort by people who both have ME and are care providers, and some people who, the people that blow my mind are the people who have no connection with ME, but found it and have become impassioned advocates for people with ME who are trying to change this so that this problem just goes away. And that's where the real head banging actually should happen. But in the healthcare part, I think we have to have this nuance, this paradox thing going on, because what's going to happen is you're going to end up medically traumatized. And I will tell you, speaking from my experience, I can't say that it will be everybody's experience, but my ME was not avoidable, but my medical trauma was. And my medical trauma is now, because of the way I've learned to manage my ME, my medical trauma is more of a daily interference with my life. I have a very narrow life because of ME, but my medical trauma, it penetrates every single activity of every single day of my life. And so what I'm telling you is think about this and realize that it is not fair, but we have to work with what we've got. And I'm with you guys, and my heart breaks when I think about people all over the country and the world that are struggling with the same challenge. But things are different. I can vouch for it, and things are slowly changing. So keep and part of this effort, part of this massaging of these clinicians is actually making the change. It's just not in a really obvious, overt way. So hang in there and keep working with it.
Thank you for sharing that. And honestly, one of the areas where I hear from patients all the time where they experience medical trauma frequently is at the emergency room or urgent care. Harper, can you touch on that of when people should decide to go to the emergency room or urgent care and what their expectations should be for that?
Yeah, that's a difficult question. It's always hard to decide to go to the ER, especially with these chronic conditions. Probably you're going to get worse from the lights, the sounds, the long wait. You're probably going to get dismissed and misunderstood. And so it's understandable why people don't want to go to the ER. How I frame it in my practice is that the emergency room is truly for emergencies. They are looking for life-threatening things like cardiac problems, severe dehydration, and infection, things that would be severe or problematic for you right now. That's why I have patients go to the ER. If there's something that we cannot manage outpatient quickly, we need to go to the ER and have it managed quickly. If you kind of go into the ER with the expectation that no, they're not there to manage your chronic illness, and they're there to find the emergent problem, it sometimes makes it a little easier. The ER just is difficult all around. Sometimes when I have to send patients to the ER, I'll spend a little time coaching them and kind of coming up with a game plan of, again, sharing a one pager that is talking about your ME, any sensitivities you may have, any treatments you may have tried for this specific issue that you're coming in with. And just try to coach them up that way. And just have people remember that more than likely in the ER, they don't understand ME/CFS. And that's not where you're getting your main support from. You're getting your main support from your caregivers, your outside providers, and your specialists. The ER is just sometimes a necessary evil of this illness.
Yeah. ERs can be really challenging to, if your expectations are that they're going to provide certain levels of care. For other appointments, Galen, you had talked about for other appointments that aren't at the ER or urgent care, that may be just an appointment like to go to the dentist or for other things. How do you communicate to them about what you have going on, but also simplify it to this is what I need?
Yeah, I would exactly say that. These are our needs. We have special needs. Need to we like I said earlier, there's a neurological condition, very severe. My son has a very severe neurological condition, and he requires accommodations. And when you use the word accommodations, it's kind of I don't know how to put it, but people kind of shift in their attitude. You're not talking about something that you want or you're being fussy, but they have to accommodate you based on the law. So we have special accommodations such as low light, you know, quiet talking if we have to talk. I prefer that you talk to me instead of him, these kinds of things. And if we call it a neurological condition and we don't mention ME, we're not complicating things to the podiatrist. My son has constant toe infections because he can't walk. For some reason, his toenails grow like this instead of like this. And the podiatrist is very familiar with us. They don't know anything about ME. But, when I went in the first time, I said, while we're here, could you turn off the music overhead? They play soft jazz or whatever, and they put me in a room in the very back. We have our special room now that's always low light and etc. And they don't know anything about ME, but it works out.
Yeah, those simple requests, like we need this addressed from this
Right,
medical appointment, but also we need these accommodations.
right.
That's helpful. I want to touch on this because this happens a lot. People will be misdiagnosed with something and it will be put in their chart, and that can really affect how healthcare providers view that patient. Harper, can you touch on, is there a way to get that provider to be able to correct a misdiagnosis in the chart so that it's not affecting their care with other healthcare providers?
Yeah, again, another complicated issue where you have to manage the clinician's feelings. Again, I'm sorry about this. That's just the state of our medical system. But if there is an error in your medical records, you can request your records. You have access to them. Find the area where the error is, and then write a letter or bring documentation into your provider and say, my medical chart says I was diagnosed with this, wrong diagnosis, but I have been evaluated by a specialist and I have actually been diagnosed with this, and bring the supporting documentation. Um, Generally, again, it's a nuanced conversation to have with the provider, to be have them be curious and collegial and respect what you're saying. But really, when you can bring in the supporting documentation to say, this diagnosis is wrong, here's the correct diagnosis, it's much easier to get the chart corrected. And I know that not everyone has access to getting a diagnosis of ME/CFS. I know that's a difficult diagnosis to obtain. So again, bringing in the ME diagnostic criteria from the Institute of Medicine can be helpful. Just whatever supporting documentation you have to say, this is why my symptoms should be labeled as this instead of this.
That's helpful. I think often the problem comes because you've got multiple specialists and doctors who are all looking at things from different lenses. And so sometimes one doctor may put in a diagnosis like functional neurologic disorder or pain disorder or something like that that maybe doesn't capture it. Amy, do you have any comments or suggestions on how patients can manage working with different specialists who may view things from different angles?
Okay. I think there's a difference between, the reality and what really happens. Or the ideal and reality. The ideal, I think, is that we have, a quarterback and we have some satellite providers around, to have that quarterback, provider, PCP, pediatrician, somebody that is going to be taking the information and just being the house of all the the materials. I know that doesn't always happen. Um, that is, I think, the clearest way for providers to be able to kind of bounce ideas off of each other. The reality piece of it is that that quarterback position is on the patients. And if people can have some sort of organization in their medical file on their computer where they just at least know where some documents are being stored, if they know that they last went to a hospital named XYZ, that they can access some imaging there so they don't have to go searching. So I think just figuring out a way to have access and kind of coordinate some of that information. But I know, doctors don't want to make an extra phone call or, I just even getting a prior authorization for imaging, it takes 2 days, for a caregiver to do, let alone a person who is, with ME. It takes a lot of effort. And I think by kind of looking at this as the marathon, it's going to, managing your care and understanding the medical system is a whole job in itself. And when a doctor is saying, go and get this imaging, it's not going to be done next week. And I think by taking away the alarm bells to say it's yes, I would love to be able to do that. It's going to happen maybe in the next 6 months. It's just not a reality for how I can access that care in a super timely fashion. So, asking the doctors also to find out what's the vital, what do I have to do? What's the information that you need that will change or direct care? Because otherwise, I think doctors make a list of all of the things that they would love to get, but they're not all necessary. So finding out, is that blood work really necessary, or can I postpone it until the springtime when I might be also doing another thing? So kind of prioritizing, organizing, those are the two pieces that I think are most helpful for patients, especially if they're their own manager of care, is figuring out what are the lines that need to be drawn in the sand of saying this is just not going to happen, or this is what's necessary for my care.
Thank you. Well, our time is up. Thank you, Amy, Galen, Harper, and Sallie, for being our panelists and volunteering your time to spend this with us. And we thank our donors who have made this possible. We thank you for joining us today, and we hope that there were at least some things that you were able to get out of it that were helpful. And we hope to see you again for our next session on Wednesday, December 10th at 10 a.m. Mountain Time. We'll send an email with the recording and associated resources at the end of the month. And please complete the brief survey if you can, that will pop up on your screen. And we look forward to being with you next month. Thanks.